Good afternoon, everyone. I'm David Kuo. I've actually recently taken on the chair of the IHSCM Digital Health Special Interest Group. And I think in that capacity, I'm very pleased to be able to introduce Tom Witcher. Is it Tom Witcher?
Yeah, it is.
Okay, who I understand is the chief executive of DrDoctor, and today you're going to be discussing use of DrDoctor to drive productivity through digital patient engagement tools. Is that right?
That's correct. And more broadly, I kind of talking about patient engagement as an opportunity.
Wonderful. Well, take it away, Tom.
Great. And just so I'm clear, like how long have we got today?
So, Jade?
I was going to say, so you can have between 20 to 30 minutes, and then we can have a discussion and some Q&A.
Oh, that's what I prepped for. That's ideal. Thank you. Great. Well, fantastic to meet you all. I'm really pleased to be asked to come and talk about this. I've got some slides, obviously, which I'll share, but before I do, I'll introduce myself. So my name's Tom. I'm the founder and chief exec of a business called DrDoctor. I started DrDoctor 10 years ago, amazingly. My background is operational improvement in hospitals, so specifically outpatient transformation and theatres productivity, looking at how you drive financial and patient experience benefits through those two mechanisms. And the business was born out of the work I've done in a number of different hospitals around the country, but trying to bring the patient into the room at the same time. Cool. So, with no further ado, so today we're going to talk about driving productivity from patient engagement, and I've got a little bit of context on what is patient engagement, how we think about it, how the products work. I want to talk a bit about the current NHS England work that's happening around patient engagement portals and the funding that's available, and then a bit about lessons learned about how you drive productivity and a few case studies from some sites. So what is patient engagement? We talk about hospitals having three slices of technology. The first one, which is at the bottom of this diagram, is the PAS, right? We've all got a PAS in our hospital, patient administration system. It was the first part of the hospital to get digitized. It's about billing, patient demographics, reporting, all the things you need to run the admin of a great hospital or clinic. The second slice of digitization was the EPR, right? And so 80% of hospitals these days have an EPR. Everything the clinical teams need to run a great service: noting, order comms, pathology, radiology, all of those bits of technology, both of which are totally necessary to run an efficient and safe hospital. The third slice of digitization is what we call the patient layer, or people are now calling patient engagement portals. It completes this sort of the stack, if you like, because it's the bit where we go outside of the hospital to reach out to patients. So the big difference between the PAS, the EPR, and the patient layer is the first two are about running a great service inside the four walls of the hospital. The patient layer is about reaching out beyond the hospital to create new workflows, and by doing so, not just improve base productivity, but also potentially change the underlying models of care, and therefore shift the health economics in a whole new way. And everything we do is in that patient layer. It only works if all three slices integrate and work together. If any of the three slices don't integrate with the others, you have challenges. Sometimes all three are produced by the same company. Sometimes they can be three different ones. But as long as they work together, then change can happen. From a patient's point of view, we think it looks a bit like this. So you have everything from your sort of teleconsults, your video, through the ability for patients to self-schedule, for patients to be able to complete forms pre or post-clinic. So we've got an example of a pre-op assessment here, although there are thousands of different use cases for forms, and a digital letter. So it's all the information a patient needs to manage their care, ideally from referral all the way through to discharge. And increasingly now we're reaching out beyond referral into primary care and picking up information from the GP record. so that patients can have a complete and seamless end-to-end journey. And if you begin to do those things, it actually enables some really exciting long-term digital transformation. And some of the bits that I'll talk about in the end of the presentation talk specifically to this. What we think really matters is you have these three kind of pillars, which is patient engagement and communication. That is about channel shift. It's about getting patients to move from traditional ways of communicating to online. Second bit is scheduling and automation, and I'm going to talk a lot about some case studies in that space later. But waiting list management, partial booking, admin reduction, all of those things fit there. And then remote data capture, which is collecting new data from patients in order that you can make triage decisions and run patient-initiated follow-up models, for example. The other bit of context that matters here is most patient engagement platforms now integrate with the NHS app. We integrated with the NHS app in May 2022. Had nearly, I think we've actually now had over 1 million logins, because this slide's a little bit out of date, but significant number of logins coming to the NHS app. The really nice thing about the NHS app is it can be a fantastic single front door for a health system. So we often find journeys start from the NHS app or from NHS login, and the NHS app now can show appointments. You can join video calls. You can now view letters. Forms are going to come soon. And patient journeys that start there can then end up in local hospital portals in a seamless way because of the way it's been designed. So if anyone on the call is thinking about a single front door across an ICS, using the NHS app as the jumping off point for patient journeys, it makes a lot of sense, we think. It brings a lot of trust. Patients feel safe and happy with journeys that start there. They're much more likely to continue. They're much more likely to go on to use more functionality. And then just the last bit of context on us before I talk about the PEP opportunity. So we now have 25% of NHS acute trusts use DrDoctor in some way, shape or form. We've got 19 million unique patients that have in some way engaged with the system, and 91 million NHS appointments that have transacted on the system over the last 10 years. So we're getting close to 100 million NHS appointments transacted. Really great geographic spread, lots in London, but also in the Midlands, the Northwest and the Southwest. We do a lot of work with NHS Wales. NHS Wales is actually where a lot of our remote data capture work started. And these days you can walk from the furthest west tip of Wales all the way through to Hammersmith Hospital, and all the sites use us, which is really quite cool. And one of the things that's exciting about that is we're also building a lot of partnerships with other suppliers. So for example, eConsult are one of the biggest online consultation providers in primary care, and we have a partnership with, and in Birmingham and Solihull, where we're in all the acute trusts and they're in lots of the GP practices. We've brought our products together so that the ICS can offer this like integrated solution all the way through. And it's something we're really keen to do more of over the next sort of 18 months or so, is look at patches where we have significant geographic spread already and work with partners to do that sort of thing and drive like big system change. Cool, so that was a bit about patient engagement portals and the context of who we are. I just wanted to include a couple of slides on the current NHS England funding opportunity around this. So there's a national ask that all acute hospitals have some form of patient engagement platform by the end of the financial year. I think NHS England have shared the local versions of these rankings, but there's different amounts of money available for these sort of green, amber, and red sites. The red sites that don't have anything at all have been asked to complete a procurement by September this year. The amber and red ambers have been asked to surface a minimum set of functionality, and then sites that are green are already doing this, which is viewing the outpatient appointments on the portal, being able to validate their waiting lists. They're offering a single point of access to change and cancel appointments, and allowing patients to view correspondence, which is a really fantastic set of functionality. But there is so much more that sites can do with a PEP. And again, we'll talk a bit more about that later. And I just thought it'd be useful to include this if anyone hasn't already seen it. Obviously, this information is available in other places, but there's 675k of revenue available for sites that have nothing to buy, to procure a portal. There's 150k of revenue for increasing levels of functionality. Plus, and I think this is the really interesting thing for this group, 250 to 500,000 pounds of revenue to go and deliver change on the ground to roll products out. And when we think about some of the productivity benefits, a lot of it comes from going and doing the change management. And I think there's a real, if people on the call haven't applied for that, and there's a really great opportunity to go and apply for some of that money to go and roll out, to go and do the delivery and implementation support around the products. And that's also available for green sites. And then there's finally a pot of money available for integration, going back to my point at the beginning about PASs, EPRs, and the patient layer having to be integrated. If those interfaces don't exist into your PAS or EPR at the moment, there is money available to go and build them, which is really great. And then there's also the opportunity to do local development. So big focus on areas with the longest outpatient waits or high DNAs. And the list is here. So hip and knee, headache, hernia, breast, cataracts, all the ones you'd expect. And specifically, they're looking at booking capability, so patients can view and book and change their appointments, using e-forms for preoperative screening, using e-forms and messaging to validate waiting lists, and then finally enabling either clinician-initiated or patient-initiated follow-up models looking to reduce follow-up load. And that last one is one which we're particularly excited about because we feel that the opportunity from PIFU is really, really significant. I'm going to talk about that a little bit more in the next section. So that was a little bit on us and a little bit on the funding opportunity. I'm now going to talk about how we think we make change happen. So having done this across 50 plus NHS acute hospitals for 20 million patients and 90 million appointments, we've built out what we call our 6-step theory of change. And what we've learned over the last 10 years is that if you try and run before you can walk in terms of this stuff, you tend not to get the return on investment or the productivity gains that you wanted. So we split it into 6 steps and 2 phases, which we think create sustainable, scalable change at pace. Within the first phase, which is all about a shift to digital, it's about taking existing processes and moving them online wherever possible and channel shifting the way patients work. We have 3 slices. The first is improved communication. So this is about taking all of the comms that would have happened over post or through the phone and wherever possible, taking them online or to text message. So asynchronous messaging to patients, getting rid of letters and replacing them with digital equivalents, reminder messages, automatic waiting list management messages, automatic referral management messages. So for example, sending out a text message to patients when they first get booked in can reduce calls to booking centres by 25%, because 25% of calls to booking centres to patients who think they've been booked, but they haven't heard anything yet. And that text message can massively reduce the admin overhead. Secondly is about getting patients to engage with digital at scale. So this is really video, it's enabling change and cancel through the web at scale across your organization. A huge part of what makes that work is granular configuration of clinics, which I'm going to talk about in a second. And then finally, supplementing care, which is your pre-clinic questionnaires, automating the sending out of those. The hard bit isn't actually getting patients to fill out a form or even designing the form. It's getting all of those forms sent at the right time such that they're all completed on the day of clinic. And the key there is being able to automate the sending of a form or information based on the information that's booked into PAS, and building out scenarios so that becomes an automated process in the background. It doesn't require someone to do it. Once you've done those 3, you can then move to the longer term outcomes, and the long-term outcomes tend to have a higher opportunity attached, but the change management journey is much longer. So improved self-referral. So this is, for example, the PIFU type models, or we're actually also seeing patient-initiated new appointments in Liverpool, which is really interesting. So allowing patients to book follow-ups or new appointments based on a set of conditions and criteria. So for example, we're seeing dermatology services that rather than booking patients for follow-up are just putting every single patient onto a PIFU pathway and sending them a form where they say, if you have a psoriasis flare-up, for example, send us a photograph, send it in, someone will review it, and if it gets an okay, you're then sent a link to book. So really quite a simple workflow. And we've seen an 80 to 90% reduction in face-to-face appointments using that. Not moving them to video, we're just removing those appointments entirely. And the other great thing about that is the patients who do come in are the patients who are high acuity and therefore need to be seen soon. So it's a win-win in terms of liberating capacity and reducing unnecessary follow-ups. Talks a little bit about 5, which is this digital first pathway. So really beginning to lean into remote monitoring, using assessments to allow virtual by default clinics. And I've got a little case study of that later in this presentation. And stratifying people into the most appropriate pathway as quickly as possible. And then finally, fully automated appointment management, which is where you have the rules engine in place to get patients fully booking without any admin input at all the way through their pathway, which can have really significant admin savings, but it also is great from a patient experience point of view. And you get a load of secondary benefits like higher flexibility around clinical leave, more likely that you'll get high priority patients seen sooner. The list of benefits you get from that is really significant. Just talking about these a little bit more. So within improved communication, the sort of things we talk about here are being able to send broadcast messages to patients. We have a tool called Quick Question, which is used for waiting list validation. Some of the challenges we've seen around this is getting booking teams to change, making sure that like any change to pathway has owned within BAU. And to make those things work, you have to really start with really strong engagement with booking teams from day one, understanding the processes, mapping those out, and making sure you build out SOPs. Engaging with digital, things like letters, notifications, and video. Again, the challenges we've seen, templates always come up when you start looking at booking, making sure that booking teams, again, are bought into this and work in real time rather than batching things up. Again, it's all about going and doing the engagement with the people on the ground. It's making sure that you have really good coverage. And it's making sure that patients really understand how these things work as well. And then finally, the pre and post clinic stuff. So this is all about getting patients onboarded and getting clinicians adopting this kind of new technology as well. So there's lots of clinical change management required, local mapping, and then getting the data back into the hands of clinicians is really, really important. You get them to put the work in up front, make sure that they then have that data to run their audit, etc., is a really fantastic success factor. For the phase 2 stuff, success factors, again, they come down to really good process change management, communication with the public about how this is going to work, and making sure that like the technical integration stuff is right. If you don't have, for example, sort of waiting lists data flowing, it can be really hard to scale up PIFU. That's like a key enabler for that. Digital first pathways, you need to make sure that you liberate the clinical capacity to do review and triage. That is a bit of chicken and egg, because once you're doing these things, you get a reduction in follow-ups, and then the capacity becomes clear, but there's a bit of an upfront cost of getting over that initial hump, which can take time. Again, this has to be designed hand in hand with the clinical teams. It doesn't work if it's viewed as just an operational, just an IT project. It has to be something which ops, technical and clinical are doing together. And then finally, like the fully automated appointment management. It can be very scary handing over the control of booking fully to a system and patients. For it to work, templates have to be spot on, the waiting list has to be exactly right. We have to make sure that it's integrated. We have to continue to validate templates, and we have to make sure that the people who are working in the booking center start to think of their jobs as a slightly different thing. It's not about booking the appointments now, but it's making sure that all of the other pieces are in place such that the automations can work. Cool. So I just want to talk in the last 5 minutes about some case studies and some examples of the benefits of this. So first is did not attend reduction. DNAs are back in vogue. I don't know if we've been in vogue. Back in focus. We tend to see about a 30% reduction in DNA rate when we switch on notifications and scheduling. This is a chart from across 18 providers and nearly 4,000 clinics and 120,000 appointments, showing the average DNA rate with allowing patients to reschedule. And you can see it goes from 12% to 9.4%. Pretty much as a step change. What we've done is we've normalized that data across those 120,000 appointments. So allowing patients to reschedule will make a significant reduction in DNA rate. Turning on reminders, we also see a sort of 20% reduction in DNA rate. So you can take most organizations from sort of 12, 13% DNA to 8 to 9, pretty much overnight by turning these things on, which for your typical trust is worth £1 to £2 million a year straight away. With no real effort, it creates lots of extra clinical capacity and lots of extra outpatient appointments, all of which help us with our waiting list challenge. So if you're not doing reminders and basic rescheduling in your organization, I absolutely would recommend this as the quickest way to make an instant win. Turning on automated rescheduling can make a significant difference to admin time. So the chart in the middle here shows how long it takes to change an appointment on the phone. So phone-based rescheduling, it takes about 225 seconds to do that. Even if you haven't got a fully automated system and you're getting patients to choose a time, but an administrator to check it, it reduces that by 70% down to about a minute to go and action a request. And obviously, if you have a fully automated system, you can take that time down to almost nothing. So we've got really significant administrative saving to be made from moving to slot-based scheduling and then automated scheduling. And a significant percentage of patients want to change their appointments. So about 5% of patients want to change their appointments. And if you multiply that by your average number of outpatient appointments in an organization, that is a lot of time spent just making and changing appointments, which doesn't need to be spent. And you can therefore refocus administrative teams on higher value activities. Thinking about reduction in follow-up appointments. We have an example here from a breast cancer service at Nottingham, where we saw a 54% reduction in follow-up appointments in these clinics, which if you scale that up across the national breast cancer services across the UK, you'd save 1 million follow-up appointments a year, which would be worth £120 million. This on its own was worth nearly 600k to the trust that it was done in. And the really amazing thing about it is you haven't just got a 54% reduction in follow-ups, but the patient experience feedback was so positive. There's actually a video case study of this on our website, talking to a patient called Sivi, and she talks about the fact that because she wasn't having to travel to the hospital so much, she could pick her kids up from school, and it stopped her feeling so much like her life was being dominated by cancer and a bit more like she was a person again. Getting this kind of change in clinical services, as I alluded to earlier, requires significant clinical buy-in and lots of change management. But the cost and patient experience benefits are so great that we're really excited by the use of more e-forms. There's also a centrally funded NHS England pilot for e-forms, which we are the current supplier for, which has, I think, 20 sites on it currently, but there is space for others, which would allow you to use this technology in a fully funded way with some delivery resource. And then just to sort of close up, I've got a couple more examples. Reduction and prioritization of waiting lists using e-forms. So everyone's got a waiting list at the moment. You can do a simple yes, no, quick question form to validate lists. Data here is from 20,000 patients that use this. We saw a sort of 30 to 70% response rate. And the average list size gets reduced by 5%. So it takes 5 minutes to set up one of these. You can send it to any cohort of patients based on clinic codes, based on lots of information, and you typically will see 5% taken off a list straight away. So again, like a really quick win, a really easy way to make a big impact on wait lists for very little. And then a larger example of using an e-form to save admin teams time. So this was from Endoscopy IHSCM in Westminster, who had a pre-clinic questionnaire that everyone had to fill out. It was on average taking somebody on the phone or somebody in an outpatient clinic was having to complete these with the patients. And it was sort of taking half an hour or so. When we got patients to begin to do them online, not everybody did it, but we saw a significant reduction in how long it was taking admin teams to fill out these forms. So across the endoscopy service at Chair West, we saved 220 days of administrative time. Again, staff loved it because their life was easier and patients really liked it as well. So a really interesting example of using a pre-clinic form to save admin time as well as having clinical benefits. Cool. Before I open to questions, I just wanted to talk about some examples of, if you thought this stuff was interesting, how we could potentially help. So as I said, there's quite a significant amount of funding available at the moment for delivery and implementation, as well as software licenses. So we put together 3 programs to help organizations that might want to look into this stuff. So program 1 is Scaling Solutions Trust-wide. This is about scoping out how you could expand what you have in terms of digital solutions around patient-initiated models and waiting lists. It would involve process mapping, understanding your current list sizes, and give you the tools you need to increase adoption, upskill your teams, and take on more rollout. Typically takes about 4 weeks to do that. The second one is pathway transformation. So this is about the clinical change. If you wanted to take on some of those kind of bigger, how do we reduce follow-ups in a particular pathway? We can take up to 6 within a pathway transformation piece of work. It takes about 6 weeks. Working with clinical teams, developing the pathway models, and if you want to, beginning to do the implementation of some solutions. And then program 3, which is booking practice transformation, which is looking at how do we take advantage of all the digital solutions we've talked about to reimagine your outpatient booking services? How do you begin to roll out patient-initiated models? How do you move to partial booking? How do you look at your templates? And how do we really put in place the success factors you need to drive productivity from moving to a much more patient-initiated, much more online model of booking, which I think is my 20 minutes pretty much up. And it feels like a good time to stop and take any questions on all of that. I appreciate I've thrown a lot of information at people quite quickly.
So Tom, that's been really great, fascinating. Thank you so much for that presentation. I'd really like to open it up to questions. I may just kick off with a couple of my own, if I may. So my first question is, does your solution, is it mainly focused on hospitals and acute care? Or, are you anticipating, similar digital patient portal solutions for the other care settings?
Great question. So we started in the acute world, and I have a tendency to still use that language a lot. We now do a significant amount of work with community trusts and mental health trusts.
Right.
To a number of community organizations that use us. The needs and challenges are the same. Some of the on-the-ground stuff is different, but the challenges are the same. And then increasingly, we're also working with larger GP federations through partnerships. So we don't directly offer anything into primary care, but through our partners, of which we've got several, we can link up the data and provide a kind of system-wide view. And as I kind of mentioned very briefly at the beginning, we've got one ICS, which is in the middle of a discovery piece of work that we're doing in partnership. And in North West London, we're also looking at kind of broadening our scope beyond the acutes and community trusts who we currently work with into primary care. So that's quite exciting.
And is that because for primary care, is that because the primary care EPRs tend to already have their own patient portal? Is that why?
It's more, there's a number of suppliers in primary care who have solutions. Some of them are the EPRs, some of them are third parties. And when we looked at it as a business, we felt like that space didn't need another competitor in it.
Right.
And it was much healthier to partner with the eConsults, the AccurX's, the clinics, and all of these guys, rather than going out of our lane. We're pretty focused on that kind of whole secondary care piece. So that was our thinking.
Okay. Good. Are there any questions around the table, as it were? Otherwise, I've got another question myself. Oh, sorry. Yes.
Carla's got one.
Carla, please.
Yeah. I don't usually ask questions here. Normally I'm just listening, but I'm currently doing a module about digital health leadership. So I thought this is quite a good time for me to get involved in this. I'm assuming that this whole module and everything that you're working on is related to people who are already somewhat tech savvy. So my question is, how would you get patients who are not really tech savvy more interested or more engaged? Because you've got something about patient engagement, so that's a good way for them to start off. But that's just my opinion.
That's a really good question. All of these digital products, you have to think about lots of different people and their needs. Everyone from the not so tech savvy through to the people with accessibility needs to the people who don't speak English. And we spend a lot of time thinking about, when you roll this out, what does it do to those different groups and what does it do to health inequalities? Although I wasn't very explicit about it in the presentation, we have a number of online tools, but we also do a lot of our work over text messaging.
Okay.
So for example, all of our change cancel workflows work over text. And what we found is that SMS is a really powerful way of getting people who might not engage in more richer digital tools to still get value. Because most people understand text messaging, are happy to reply to a message. So that works really well. The other things are designing products that are very high up the accessibility spectrum. So thinking about the language used, the colors, etc. And we work really closely with NHS Digital on that, and all our products are AA from an accessibility point of view. And then doing the patient outreach, doing the posters, doing the training, making sure that people are, you don't just throw a digital solution in their face and expect them to use it. You have to support them with it at the same time. So
yeah. Okay.
The last thing that's worth saying actually on that, because it's a really important question, is the other thing we've noticed is when you automate scheduling, for example, not everybody will use it. Some people will still want to phone up. It's about 80% of people, 70-80% of people will do it digitally and the others won't. The people that don't ring up, but because suddenly you've got most of it happening automatically, instead of phoning up and not being able to get through, they can get through to the booking center. And when they do get through to the booking center, the person on the other end of the phone isn't quite so stressed and has got a bit more time for them. So actually, can give them a bit more time, and maybe they need transport booking or they're a bit confused and they're talking through it. So by kind of digitizing for the 80%, the 20% that do need a bit more of a personal service can actually get it, which is a really nice example of it kind of, by helping some people, you actually help everybody.
Okay, great. Thanks for that.
Thank you, Carla. Richard, you've got a question?
I've unmuted. Hi, Tom. Thanks very much. Really good. Richard from HCI. I guess there's two questions they link. One, how big do you think the opportunity is? And what's getting in the way, Tom?
Yeah. I mean, I think the opportunity is, I think we're talking about the sustainability of the healthcare system as we know it. I really do. It's that much. It's,
Yeah.
you know, we can't keep working the way we've always worked. You know, there's a great quote from Leslie Watts, who's chief executive at Chelsea, saying, you know, we do not intend to have a physical outpatients department in 5 years' time. She's not, obviously they are going to have it, but they're not going to keep building it at the rate that they are, right? Like we have to think about, how do we look after people at home? How do we give people like stratified need-based care? So I think it's massive. That's how big it is. What's getting in the way? I think it's a number of things. So I think the reason I really focused today on that like theory of change is we have found projects that don't think about getting patients to channel shift their behavior really early on fail. And if you put a lot of time and effort into doing all the mapping, etc., clinical buy-in, and then you fall over at that first hurdle, people just give up. And, you know, we all know how burnt out everybody is in the healthcare service at the moment. The thought of more change is really scary. And so for these things to work, got to start with some quick wins, put something on the ground quickly, deliver a financial or patient experience or outcomes, measurable impact really early, and begin to build a flywheel before you try and do too much. You know, it's about proving to people that this is possible and will actually have an impact quickly, not over the course of like 5 years. I think funding is always a challenge. I think integration is always a challenge. The money that's available centrally for both of those things is fabulous. I'm really, really pleased they've decided to spend the money on implementation support as well as technology, because that's always where it falls down, is that there's funding for the tech and not for the change. So the fact that there is a significant amount of money for change is huge. And then the last, this is a very long question, Richard, I'm sorry, but the last one for me is vision. And the organizations that have done this at scale have done it because they have executive teams who have a vision for where they want to go. And it's like, you can't do digital really well as an add-on. You have to have leaders that can see the future and want to get there, realize it's steps to getting there, but you've got to have that vision somewhere in the organization.
Thank you. I would concur in every sense. Thank you. Really good to hear that from you. Thank you very much.
No worries.
Any other questions? So my next question is, how does your patient portal compare to those that, you know, the EPR suppliers have, like the one that Epic has?
It's a great question. So most of the EPR suppliers have something now. The things that we have found that make our product different and are critical to delivering results at scale are, how easy is it for a patient to log in? How much friction is there? So we've all used digital services. Like, think about checkout, right? If you buy something from Amazon, it's really easy. You probably don't have to enter your password. The shipping is free. And if you go and buy something from, got a lot better recently, right? But some sort of home-built website, and it's hard to create a user account and it takes a long time. So thinking about friction and the consumer experience side is massive. So for example, our portal, a lot of the transactions you can do without a user name and password. You just have to know your demographic details and have your mobile phone. It's registered on the pad. So that's a really important bit about getting scale. A focus on the patient-initiated booking models. So most of the EPR portals don't have PIFU models built in. They don't have the rules built in. They don't have the granular control that you need to do that. And then the last bit, and I think this is probably the most important one, is within most health systems, not all the local trusts have the same EPR. And if you're using the EPR portal, which is, you use the Epic portal, for example, MyChart, which is fabulous, but it only works at an Epic site. Whereas our product is EPR agnostic, so we can present the information across the whole ICS, or more broadly in one place. And that's really important when you start to think about how you make systems work really well. So in North West London, for example, we're beginning to do demand sharing across organizations. making sure we utilize the capacity properly across the whole patch, not just within a single acute. And you can't do that when you have a portal which is tied to a single EPR instance. So I think that that's a really important factor when we think about the next, probably not so much today, but we think about the next like 3 to 5 years time, having systems that work, products that work across the system is incredibly important.
Yeah, I mean, if I could just follow on there, one of the big challenges, which I don't think anyone has solved, is how to allow the patient's electronic record, move across boundaries, across hospital boundaries, across ICS boundaries. Okay, your portal isn't the full medical record, but at least you're working, you're following, you could be following the patient, couldn't you?
Exactly. Exactly right. And we've purposely designed our workflows so that they do exactly what you just said, that they can follow across the system. And the other bit about it is my view has always been, as a technologist, that the portal itself should be transparent. Like, we're not trying to build a Facebook here where patients keep coming back. Like, you want to make it as quick and easy for a patient to do the transaction they want to do and leave. Book and change, fill out a form, see the next step in my referral process. And a lot of the platforms out there aren't designed for that. They're designed more as kind of, let's view the whole record, which, like, MyChat does really well, and it's a great product, don't get me wrong. But if you need a million people across South London to be booking everything, you want a light touch, like, relatively transparent product, I think. You also, like, there's a cost implication of that, which is using a product like ours is actually significantly cheaper because it's not trying to do everything for every patient. You don't need to give a high acuity chronic patient the same level of functionality as someone who's coming in for fracture clinic. And one of the things about the way that we've put our solution together is that organizations don't end up paying the same price for those two very different use cases.
Yeah, I mean, I get that. I just think it's, well, let me just check with you, Tom, because I still perceive a conundrum in all of this, so that, I mean, in a way, our conversation is about, well, which is better, your portal A or portal B?
Yes.
Whereas from the patient's or the citizen's point of view, I want as few portals as possible.
Yeah.
But I also want to be able to do the things that yours does and the things that MyChart does. Okay, because so you say, well, you might say, well, portal A is designed to do certain things that portal B doesn't do. It's not trying to, but then that just leaves me, the patient, with having to have multiple portals to satisfy the whole range of requirements I have, because I want to be able to do fast booking, but I also want to be able to see, my lab test results, and I want my proxy parent, if I'm ill, I'm a child and ill, I want my parent to see the drugs that I'm on. Okay, so I think we all want that, but the conundrum I'm trying to point out is that at this point in time, there isn't an overall solution to my requirements.
You're correct about that. I think that's where the NHS app becomes quite exciting, because they've built these APIs into the back end of it so that such that we can integrate with it, MyChart can integrate with it, patients their best can integrate with it, everyone can integrate with it. Over time, my hope is that will become what you just described, and patients will end up actually going into lots of different places to do whatever it is. but they don't know that they're doing that because the data is being fronted in a consistent UI. We're a long way from that dream at the moment, but I think that is what the system is pushing for, and I my personal view and the way we're designing our products is to enable that, because we should be thinking about the patient experience first and foremost. And if we can get to that point, I think it would be phenomenal, but we're a long way off it right now.
Thank you. Any other comments or questions? One last point from me. What about the shared care record? Do you have any intention to link to it?
We've talked about it a number of times. We don't at the moment, because for most of our workflows, it doesn't make sense. But now we are beginning to do more context pre and post hospital visit and into primary care. I think it begins to be valuable, but to date it hasn't been. So yeah, it's probably a long way of saying it is on our long-term roadmap, but not our medium-term one.
Okay.
Yeah.
What about something for our social care colleagues?
That's a great question as well. It's absolutely critical. We're actually talking extensively to GraphNet and System C about trying to link up the data that they have from social care. We think that's really exciting. It's pretty obvious, isn't it, to all of us that first you've got to bring together community, mental health, primary care, and acute. As soon as you've done that, you've got to bring in the social care data, and the benefits are the same. Yeah, there's lots to do.
I wouldn't see that as serial. I think it should be concurrent.
Fair. For more resource and more days, hey.
What can I say? So, listen, I thought that was a fascinating and in some ways important discussion. So I really want to thank you, Tom, for taking the time to introduce and describe your services.
No worries. Thank you. Thank you very much for having me, and great to meet you all. And thanks for the great questions. I really enjoyed it.